Dr. Mark Constantian, welcome to Shrink Wrap Radio.
Thank you, sir. Thank you for having me on.
Yes, well, I'm very excited about this opportunity to speak with you about your work as a plastic surgeon. I've never had the opportunity not only to interview a plastic surgeon, but to speak and listen to a plastic surgeon. And so this is exciting for me. And I believe within the field of plastic surgery, you have a specialty.
Right now, my specialty is primarily nasal surgery. I'm in southern New Hampshire, and when I came here in 1978, I was the only plastic surgeon except for 3 at Dartmouth, which is about an hour and 45 minutes north of here. So I did everything, mostly hand surgery, lots of reconstructive surgery, the first breast reconstructions, the first big flaps to cover large wounds in the legs and so on, that nobody had done that before. So it was wonderful for me, and I located myself specifically in a place that needed my services. And I thought I'd be like the local guy. I was going to be Doc Adams on Gunsmoke, and nobody would ever hear of me again. But I got more and more interested in nasal surgery as time went on, and began to write about it, began to teach about it. And because so many patients with nasal surgery have body image disorders manifested, that got me into this area, and I started reading about it.
Yeah, I've got a little bump in my nose that as a teenager, I was very self-conscious about that, partly because my little sister would tease me mercilessly about that and other supposed flaws about my body. But it came to be an asset, I think, so I'm glad I didn't change it.
Me too.
I think when we're growing up, we're very sensitive to our appearance and our body, and most of us insecure, just pretty universal, don't you think?
I do, and I think it's probably worsened by social media. There's some people who've studied that, and certainly eating disorders and other kinds of shame are associated with social media. But it also has to go in, don't you think? It depends on someone's boundaries. If you've got a sense of self-worth, then criticism doesn't penetrate the same way as if you feel shamed.
Yes, I think so. Now, who did you write this book for?
I wrote it initially to explain to my colleagues what we were all seeing, and what my colleagues just called craziness in patients. And the hook that made it particularly interesting to them now is because people will go on social media if they hate their surgeon enough, and can really hurt a surgeon's practice. But I really wanted, as the more I read and the more I thought I was putting things together, the more I wanted to reach mental health workers as well, therapists and writers, because I thought the way the patients I saw were different than the ones they were seeing. And I wanted to make sure that that they understood what I was seeing.
And now you were just saying something about that I didn't quite understand, that you wanted other people to understand what you were seeing. I'm not sure who the other people were that you were referring to.
I'm trying to reach patients whom I hope will recognize themselves in the vignettes, so that they can get the right kind of treatment and understand themselves better. I'm trying, and so they have good therapy instead of surgery. I'm trying to reach surgeons who don't understand why some patients seem irrationally happy with a result that ought to be good. And I'm trying to fit my ideas into what's known in the mental health literature, because of course I see, and plastic surgeons see, a different body of patients than mental health therapists do.
Yeah. So your book, in fact, is deeply psychological. How did you acquire the psychological knowledge to write such a book?
I pored over the literature. Everything in here is really drawn from the mental health literature. None of the ideas that come into my assembled theory are my own speculations, except that they're backed up by original clinical research. But the ideas are all from the mental health literature. I operated on 3 patients with body dysmorphic disorder in the 1980s when I was still a young surgeon. And they had such turbulent courses that I thought I had to find out what was going on. One was a university professor who gave up her job and would deserted her family and said she would only shop in a distant city so nobody would recognize her. One was a doctor's wife who became a recluse in her house. One was a man who tried to cut off his nose with a razor because he thought the bridge was too high. He didn't only succeeded in cutting the skin, but all of these people had very good results in terms of being people I could show in one of my teaching courses. The technical result was good. The patients were devastated. And I thought, I can't do this again. I've got to find out what's going on. And in the mid-'80s, there wasn't too much information. So I read, and then I began getting interested sometime later in childhood development and the ravages of childhood trauma and shame. And I went back to the literature again and started reading the PTSD literature and the childhood development literature and the body shame literature and the body image literature and the BDD literature. And each group of specialists was asking questions that other groups could answer, except they didn't cross-pollinate.
Right,
So
right.
as I spent really 4 years reading. There's 830, I think, references in the book.
Oh,
And
yeah, it's heavily referenced. And as a professional psychologist, clinical psychologist, I congratulate you on what you've done. I wondered, well, maybe he got a ghostwriter here, you know?
I read every one of those papers myself. And it was,
Yeah, well, good
I
for
didn't
you.
start out to write a book. I started out to understand what was going on, because
Uh-huh.
the thing that always troubled me about the body dysmorphic literature, and it's really still true today, is that body dysmorphic disorder is supposed to just arise out of the blue. Suddenly, when people are 14, 15, or 16, before which time everything was perfect, they suddenly become obsessed with the body area. And why I'm involved in this is that across all cultures, the nose is the most commonly involved body part across the world.
That's very interesting
Yeah.
because just yesterday, I have a psychological friend in Iran, and I was talking to him on Skype, and I mentioned that I was going to be speaking with you, and he said that he sees tons of women walking around in Tehran, where he lives, who have had nose jobs. That it's a very big thing. I was very surprised to hear that. I would have thought that this was kind of a uniquely American phenomenon.
No, it
And
isn't. And here's a little factoid. I was participating in a symposium in Dubai about 5 or 6 years ago, and a lot of Iranian surgeons were there because it's common surgery, and the people want the nose westernized, if you will, the bump taken off. It's not aesthetically, some people, what they want. But having a rhinoplasty is such a prestigious status symbol in Iran that women will wear splints over their noses, even if they haven't had the surgery, because it makes them look more important.
wow, wow, that just really underscores how sensitive we are about our appearance and how universal that is, and also the importance of the face. So, yeah, in fact, the subtitle of your book is, and I'll hold the book up actually so that people who see this interview on YouTube will see that it's high quality paperback, paper bound, and not super thick, but thick enough. So the subtitle is The Face of Trauma. We'll get into that some more, but in fact, it, it makes me aware of just how important our face is. You know, in psychology, we talk about the persona, and the face is such an important part of our presentation to others and of their reactions to us that we're always monitoring all the time. So your book's been a real eye-opener to me in terms of the dynamics between the plastic surgeon and the patient. And I want to get into, you've started us off talking about body dysmorphia, and we'll get into that. But before that, I just want to make a little stop at, it must go well sometime, importantly well, right? And that's, you wouldn't be in business if I mean, there is a positive side of plastic surgery. I guess that's what I want to say. Do you find that there are times where having a plastic surgery helps a person's mental health?
Definitely. I think that's true most of the time. And the key, I think, is the difference between body dissatisfaction and body shame. If you are unhappy about your appearance, but you have a sense of self-worth, you're unhappy because some aging change has happened, or you don't have the figure you did before you had children, or you have the family nose and you don't like it, and yet you have a sense of preciousness and value, then plastic surgery is very effective. People have the surgery, the surgery goes well, they're happy, they go away content. It's when people have body shame and they feel that their self-worth is determined by how they look. That's when plastic surgery is never works, because the real goal of the patient is not to get rid of a deformity, it's to feel um, valuable. And interestingly, one of the key piece to me in the mental health literature was a paper or a series of papers by Bernice Andrews, a psychologist in the UK, about 20 years ago, where she had identified various types of shame, behavioral shame, the way I act, characterological shame, the kind of person I am, and body shame. And she said that body shame was the most common kind of shame that resulted from childhood trauma. And I thought, that's what ties everything together. So when patients have what the surgeon considers to be a successful surgery, and they come back and they start saying things that seem out of context. Patients say to me, you destroyed my life. What you've done to me borders on the criminal. You've taken away my family, my friends, and my joy of living. I trusted you and you betrayed me. This is weird stuff. It's not like saying there's a little irregularity or something's not symmetrical, can you fix it? It's a personal attack against me. And that's what used to disconcert me, because I think
Sure.
that this doesn't go along with what we're even talking about. But if my idea is correct, and these patients have been shamed or traumatized in childhood, as my data shows most people have been when they react this way, when they're addicted to plastic surgery. If they go through the surgery looking for self-respect, self-esteem, feeling I'm not defective and I won't be defective anymore. I'm defective because of the way my nose looks, for example, and I won't be defective after the surgery. And then they come out feeling the same way they did. They go right back to that childhood wound, only now the surgeon becomes the perpetrator. And that's the reason they lash out saying things to me that would have been appropriate to a childhood traumatizer, but is not appropriate in adulthood. This is the midbrain speaking. It's not the adult cortex, and
Yeah.
patients are completely unconscious of that, because
Right.
there's very little connection between the cortex and the midbrain. So they have this awful feeling. They don't know why it's happening, and they have to find someone to blame.
Yeah, you mentioned plastic surgery addiction. And of course, Michael Jackson is a very prominent example, I think, of that, um, where it just became clearly obvious to the world that something weird was going on there as he began to look more and more disfigured and unlike his original self. And there are other media examples, celebrity examples. In preparing for this, I Googled celebrity something or other, and there are sites that kind of specialize in showing, you know,
Right.
the effects of surgery addiction. Uh, do you have any particular insights about the Michael Jackson case or other things to say about addiction in relation to surgery?
I think he's the poster boy for what I'm talking about. Everyone knows he had a very abusive and traumatic childhood. So despite, this is the fascinating thing about it, despite how famous he was, as accomplished, a wonderful singer, the king of pop and so on, and adored, he still felt a lot of shame. If you read Brian Wilson's autobiography, very interesting book, his isn't body shame, but it's the same problem. He is driving couple of years ago toward the Hollywood Bowl where he's about to perform Pet Sounds. And it says, Brian Wilson, Pet Sounds, sold out. And he says, then the voices start coming into my head. Suppose the audience doesn't like me. Suppose the audience doesn't like my songs. So he goes right back to the traumatized child, hearing the words of his father, who was very destructive and abusive. This is the way shame works. It gets trapped in the midbrain. And that's why I think the cure rate for a lot of kinds of self-harming problems and addictions is not very high, because it's not a rational thing. I could spend all day talking to Brian Wilson and saying, look how famous you are. Look how much music you've done. Look what you did with the Beach Boys. Everybody says you're a genius of a composer. And he'd say, yeah, that's all logical, but he wouldn't leave feeling different than he is. It's
Right.
like trying to talk PTSD out of someone.
Yeah, and it also, in that sense, is closely related, I understand, to OCD, obsessive compulsive disorder, because they've got a fixed idea that they're not going to just be easily talked out of.
That's right. And OCD is related in the literature to childhood trauma as well. So my idea is that BDD doesn't just start out of the blue, after which self-esteem disappears and the family problems occur and other connected disorders like OCD appear and the patient becomes housebound or stops going to school, and the worst ones commit suicide. I think the problem is there before the obsession with the body part. I think that the self-esteem problems, the family dysfunction, the feelings of self-worth are already there. And when you are shamed, you become closed off, you become walled off, and you're and sequestered, and you look for ways to medicate that pain. So it just depends on which one you choose. You choose an eating disorder, you choose obesity, you choose depression, you choose drug or alcohol abuse, you choose plastic surgery. It just depends on how you decide to medicate that pain. You choose cutting. All of these things are individually linked to childhood abuse and neglect. There's a very interesting book written by a man named Johann Hari, which traces the whole drug war. And right in the middle of it, he says, it began to occur to him that maybe something preceded the drug abuse and the alcohol abuse, that just didn't start in an otherwise normal individual all of a sudden. And I think it's exactly the same thing here. So to me, all these self-harming behaviors are connected, and they start in the cauldron of bad childhood experiences and then manifest in dozens of different ways, all of which have individually been connected to childhood abuse or neglect in the mental health literature.
Yeah, that certainly makes sense. And your book really was an eye-opener for me in terms of seems like the surgeon is taking a big chance as to whether the patient will end up satisfied or dissatisfied. And it's like rolling the dice in a way. And so one of the things that you write about is the Edgerton study that looked at patient satisfaction outcomes. And I don't know if there's a way for you to kind of give us an overview summary of that set of findings. And when was that study?
His first paper was in 1960. He was at Hopkins, and he had the foresight to have a psychiatrist in his plastic surgery division. And he did when he was at the University of Virginia, where he arrived the same year I got there as a medical student. And it's interesting that after all these years, I'm back now writing about the same thing he was writing about. But BDD didn't come out in the mental health literature in the DSM-3R, I think, till 1987. It actually appeared first in 1960 in his papers, talking about the patient he called the patient with minimal deformity. And he'd done a survey of 700 plastic surgeons and asked them to describe the patients with minimal deformity. They all had self-esteem problems, they all had family problems, they all had life adjustment problems, and they were all looking for surgery on negligible deformities, and they were never happy afterwards. And these surgeons all said, don't operate on these patients. So There is a lot of patient selection in what you're talking about. It's not rolling the dice. It Good surgeons learn how to assess patients well. And people always ask me, I taught for a course for years called My Most Unhappy Patients and what I learned from them, alongside my technical rhinoplasty course at our national meetings. And people would always say to me, all right, so who do we know? How do we know who to operate on?
Yeah.
And I developed a 5-point checklist that I used in my mind. I did it unconsciously, and I had to make it conscious to teach it. It had to be something I could see. That eliminated the perceived problem. That had to be something I thought I personally could fix with a high likelihood of making the patient happy, and a high likelihood of technical success. I had to feel that the patient was manageable and that they understood that perfection wasn't the goal. That the goal was the best possible surgical result. But I've elaborated that now because I think what surgeons need to look for is we need to look for functional adults, and that's most plastic surgery patients. The patients with body dysmorphic disorder or addiction to plastic surgery are the ones who are never going to be happy, are the uncommon ones, but they're the most memorable ones, and they're the most painful for surgeons to have in their practices. So I think I'm looking for now 5 things. I'm looking for a sense of self-worth. That has to do with patients who make contact with you, eye contact, they're relational, they have a sense of humor. Patients who have good boundaries. They aren't too sensitive to what you say. They don't interrupt and talk over the surgeon. Patients who don't distort what I'm saying. So if I say, that seems to really upset you, they say to me, you're telling me I'm a bad person. That's a distortion of reality. And they have to have evidence of good self-care, living lives in moderation, so that when they've gone through surgery, if it's been unsuccessful, they assess the risks of surgery appropriately. These are signs of adult behavior. So we're really trying to distinguish the patient who comes in because of shame from the patient who comes in because of dissatisfaction. The
Yeah.
former can't be helped surgically.
So I take it you don't have a diagnostic instrument that they fill out, a paper and pencil kind of thing to screen them?
No, I
It's all
don't.
your judgment?
I don't, because I've tried some. I tried one for Dr. Catherine Phillips, who was at Brown. She's at Cornell now. For many years, a very prominent body dysmorphic disorder researcher. She had developed an instrument that she'd used in cosmetic dentist offices, and she gave it to me to try out 20 years ago. But the questions I thought were too transparent. How many hours a day do you think about your nose? Do you stay at home? And so on. Patients aren't going to answer those questions because they want to have surgery. So they're on their best behavior. And this is where I get trapped, because I see patients come in my case, who've had multiple prior surgeries often. And even if their original motivation to me was suspect, now they have real deformities and real airway problems. And so my question is not, would I have operated on this patient the first time? It's, can I operate on this patient now and get him or her through the surgery? The whole thing that got me into looking into childhood was the histories of these revision patients, because I ask my staff, when a patient calls for a revision rhinoplasty, you've already had 1 or more surgeries, the staff says, bring in photographs of yourself before you had any surgery, because I thought it would be a good way for me to understand what had happened and for me to explain to the patient what I needed to do. And often the noses look totally normal, nice and straight, no bump, no asymmetry, no breathing problems. And so I'd say to the patient, so lead me through this. What were you trying to accomplish in your first operation? Well, I was trying to look as pretty as my sister. Well, I wanted people to love me, one man said. Another woman said, I wanted to look as beautiful as my mother. A woman said, my mother said, I wanted an abortion, but it was the 50s and I had to have you. My father told me I was the ugliest baby he ever saw. And I thought, these aren't indications of surgery. What's going on here? And so I began to dig deeper. I wrote 2 papers 5 years ago about patients with who originally had straight noses, the ones I've been describing, no bump, no asymmetry, no crookedness, no breathing problem. Just talking to these patients, the prevalence of childhood abuse and neglect was over 90%. So that's what started the research that's in this current book, where I've actually looked at 219 of my own patients and charted the kinds of childhood abuse and neglect that occurred in those
Yeah.
patients.
So what happens on the surgeon side, that there are surgeons who see that there's already been plastic surgery and this person is coming for revision? I'm thinking about the kind of surgeon, hopefully that's pretty rare, who, I don't know if it was just one surgeon who worked on Michael Jackson, or did he go to multiple surgeons?
He had multiple ones, but he had some that operated on him several times, and that's partly the surgeon's fault, but I think it's understandable because in these patients, I know that these patients that I turn down are going to go somewhere and have the surgery. And
Hmm.
if you're the kind of surgeon who likes to be in the jet set crowd and you think, well, he's my patient, and if I turn him away, he's going to be somebody else's patient. And why shouldn't I be Michael Jackson's surgeon and his buddy and go to his house and be on his plane? You get sucked into that sort of thing. It's not a
Yeah,
good thing, but I understand how it happens.
yeah. There, I would think that the insurance premiums must be through the roof. Do plastic surgeons pay extremely high insurance?
They are high. I think they're probably not as high as they are for obstetricians, gynecologists, or neurosurgeons, but they're
Right.
certainly higher than they are for family practitioners. It depends on who insures you too. If you go to companies that are really selective about the surgeons, they insure the premiums aren't too bad, but they're
Uh-huh.
they're high.
Yeah, yeah. I've actually, you've given us the sense of some of these letters, and you've got a number of examples in the book. I'd like to read one just so that, and I think it was very courageous of you to put this in the book, to kind of show this sort of, uh, and I guess it comes down to your own self-esteem is good enough, strong enough that you can show, what these things that people are saying about you, but that are a distortion on their end, not on your end.
Well, I wanted that's everything where I quote a patient, someone has actually said. I've tried to
Yeah,
make these a little more entertaining in some cases, but none of it is fabrication. But if I don't portray what surgeons really go through, it won't be valuable to the surgeons or the therapists. And I want some of these patients to say, that's me. I understand that anger in that person, and I want this guy to explain to me why I feel like that.
yeah. And so I imagine too that this would be valuable reading for other plastic surgeons who maybe aren't as forthright as you've been here, and to realize, well, I guess it's not me.
Right.
This is, yeah,
It comes down to patient selection for other surgeons. That's what I'm trying to get
yeah,
for.
yeah,
That's the benefit for my colleagues, I think, as
yeah. I've
well as
got
some
to
understanding. I don't
put on my
try to take these
glasses
patients crazy.
to read this. Okay, so um, this is more or less a quote from a patient, I guess. It's now the start of the 7th month. The distress of waiting to heal is more than I can bear. Every day at 3 o'clock, my nose swells so much it cracks my makeup and I have to leave work. My sister told me that my looks are ruined. I have not heard one positive comment from anyone. It's cruel to leave me like this. Complete strangers stare at me on the street and ask, "What have you done to your nose? How can you walk around like that?" Even the postman turns away from me in disgust. Doctors on the internet say that their patients do not swell and are happy right away. I know that you don't consider me an attractive person, but I'm begging you for compassion and help. I just want to thank you for effectively ruining my life. Each plastic surgery I have seen has, each plastic surgery surgeon I have seen has admitted that my nose is too wide, but that I should go back to you because you're such a professional and would be able to fix it. And you certainly would not want an unhappy patient. No one will operate on me because they are intimidated by you. So she's with one hand puffing you up and on the other cutting you down.
That's right.
We know that you don't care if I'm happy or not. What you did to me, my nose, my face, my life, it's unforgivable. It borders on the criminal. I thought I could trust you. I know you left the operation in the middle and never finished it. Another surgeon tells me you gave me a nose like a truck driver. He knew it didn't do something I would, if he knew if he didn't do something, I would end my life. Now it's worse and I need money. You may be a professor and write textbooks, but I know you have disfigured many patients, and don't think that God doesn't know it. Wow, that's harsh, and quite a bit to have to take on. I think psychotherapists generally don't get quite such intense negative feedback. There is such a thing as negative transference, but I've never read anything quite like that in the psychological literature.
It was painful. In fact, she went
I
and had
think
surgery
so.
by somebody else afterward. She had a good result, but she was unhappy almost right from the beginning. When her sister came with her to her, when I took the bandages off, and she said, I told her she should never have gone through this. Look how you made her suffer. So the sister is already setting the stage for the patient to be unhappy. The sister's angry at me and she hasn't even seen the result. This was an uncomplicated surgery in the sense that she went through it well. She got the result that she had asked for. And then, but immediately she was unhappy within a few days. And I kept seeing her over the course of a year. All the things you read there didn't come in one package on one day. I probably would have stopped my heart if I'd had to listen to all that at once.
Right.
But I'd see her back. I'd force myself to see these patients just like I do anybody else. And at the end of a year, I said, I just don't think I can help you with anymore. You haven't got any problems that I can see. In fact, when she's told us that every day at 3 o'clock, her nose swelled, her makeup cracked, I thought, oh, good. We had her come in at 2:45 so I could watch it happen. And of course, nothing happened. But some of the things she says are patently impossible to believe. As the postman recoils in horror. Total strangers stop her on the street. I mean, maybe
Yeah.
she really believes this, but the average person reading this is going to say, this doesn't even make any sense. How can those things don't happen? But she did have surgery by someone else. And she wrote me, that's when she wrote me and said, the surgeon knew I would end my life if he didn't operate on me. These kinds of stories, when they appear in various forms in popular media, People magazine I'm thinking of because it comes to the office, and there have been 2 articles about it recently. People having unhappy experiences and then thinking of suicide as the option. The response of the writer is, isn't that awful what this person went through? And aren't they brave to come and talk about it? There was just an editorial a few months ago in the American Medical Association journal by a young doctor who was recounting her days as a trainee. And she said how bad the senior doctors were with her, how rough they were with her verbally. And she said, I thought of killing myself. And the gist of the article was the same thing. Isn't medical training tough on women and on residents? And I thought to myself, wait a minute. I mean, she doesn't like medical residency training, which admittedly is hard. The only option she can think of is suicide. What about complaining to HR? What about changing residencies? What about changing careers if you decide you don't like medicine that much? Suicide isn't the only option. So there's dysfunctional thinking going on here that
Yeah.
people miss. There's just a few weeks ago, this fits exactly into what you were talking about with all the addictions. A singer in People magazine was writing about her childhood abuse. And she said, then I developed obesity, eating disorder leading to obesity, depression, drug abuse, alcoholism, and body dysmorphic disorder. And it was the same reaction. Isn't she brave to come out and talk to this and talk about this? And isn't it good that she's feeling better now and able to share her story with other people? And isn't it awful what happened to her? And I'm saying to myself, nobody is putting these pieces together. They're just listing them like I have a 6-bedroom house with 4 bathrooms. You know, they're not disconnected facts. That childhood abuse and neglect is the origin of all of those other kinds of self-harming or addictive behaviors. She's medicating herself to try to feel better. It's exactly what people do when they drink. And there's a family incidence of body dysmorphic disorder, anywhere from 6 to 20%, just like alcoholism. It quote runs in families. I'm suspicious when I hear that now too, because you know English runs in my family, but that doesn't mean that it was inherited.
Yeah. Well, what about the brain? I know you've got a section in your book. You've got a wonderful diagram showing all these different brain systems that seem to be implicated in body dysmorphic disorder. Is there any way you can give us the 40,000 foot view of
Sure,
that?
sure. When we are born, only our brain stems are working. So we can
Mm.
eat and sleep and cry and pee, and that's it. And then our midbrains start coming online, and they are programmed by our environments as ways of helping us understand our environment. So they teach you learn whether the world is safe or not. You learn what happens when you cry. You learn how important you are in the world. You learn whether things are dangerous and whether grown-ups, bigger people bigger than you, can be trusted. So if you're a baby lying in a crib and you cry and someone picks you up and rocks you and cuddles you, you get one view of the world. If you cry and no one comes because mom is drunk and dad is drugged out, you begin to think, I'm not that important. It doesn't matter to anybody if I cry. If you cry and someone comes and hits you because you're crying, you get a third view of the world as a dangerous place in which I better keep quiet or I'll get in trouble. Something bad's going to happen. I'll get in trouble. And this is the level at which trauma is inflicted. This is the brain that's operative for the first 4 or 5 or 6 years, and then gets overpowered eventually by the cortex, the executive brain, which really doesn't start working till the child's about 6 years old and keeps working till they're 21. And the connections between the cortex and the midbrain and the limbic system, the trauma center, the emotional center, those begin to disappear, so that adults have very little way to, except for a few midline brain structures. Bessel van der Kolk in his book talks about the mohawk, the central area that connects from the cortex into the few midbrain structures. Most of those connections disappear. So people they don't recognize that they're being triggered to childhood memories. And this is why when patients start saying things like the woman you just read, they aren't appropriate things to say to a surgeon who's tried to help her and gotten through her surgery successfully. They're the kinds of things you say to someone who has been deliberately cruel or shamelessly abusive. You ruined my life. You destroyed everything around me. I hate you. I trusted you and you betrayed me. These would have been appropriate things for her to say at age 4 or 5 to whoever was treating her badly. They don't make sense when she's saying them to her surgeon at age 45 or 50.
Yeah.
And in my patients, the patients who started off with childhood abuse or neglect and have had multiple cosmetic surgeries of any kind have a prevalence of childhood abuse or neglect that's 91%. That contrasts to my overall patient group, which is 80%, and to a general medical study that was done at Kaiser Permanente, of 17,000 general medical patients where the prevalence of childhood abuse and neglect was 64%. Still amazingly high, but not as high as it is in my plastic surgery patients.
Yeah, I think that last thing that the last study that you're talking about is, were you referring to what's called the ACE study?
Right.
Adult childhood, what, adult
Adverse childhood experiences.
adverse childhood experience. Yeah. And I think that was a very important study that cited pretty widely. Um, Tell us a little bit more about that, because not everybody will be familiar with the ACE study.
It was a huge study, and I wish everyone were fluent in it, every physician and patients, because you see the applications of it all the time. It started off at Kaiser Permanente, a very good HMO in California, with a computerized database. So their patients are not a disadvantaged population. They are mostly middle class, they have jobs, they have good health insurance, they're 80% white, 10% Asian, 10% African American. And they started out originally with the study as a weight loss program. They'd figured out how people could lose 300 pounds in a year on basically a supplemented starvation diet, and thought they'd cured morbid obesity. Instead, they had a 50% dropout rate. They had suicide attempts, they had depression, divorces, everything went wrong. And so they thought that there's got to be something going on here. And they realized, to shorten the story, that obesity was a solution for a lot of these patients. It wasn't a problem. They were obese for a reason. The two prominent reasons were sexual abuse, so that they had become obese to become repulsive to their abusers, or being picked on and being tormented, so they wanted to become so big nobody would bother them. And so they began to look for 10 very common types of childhood abuse and neglect. And they're not unusual ones. Emotional abuse, people ridiculing you or criticizing you a lot. Emotional neglect, where nobody cares if you're around. Physical abuse, physical neglect, not having enough to eat or wear. Violence against the mother. Sexual abuse, divorce, alcoholism, drug abuse in the family, imprisonment of a family member, or suicide in the family. And in those 10 questions, 64% of their patients had at least one answer, which stunned them. The average number, I think, was 3. And they were able also to correlate the number of positive answers with adult health. So the more positive answers you had, the higher your chance of developing high blood pressure, high cholesterol, heart disease, cancer, multiple sclerosis, primary pulmonary fibrosis, depression, drug abuse, and so on. And what was stunning, if you think about it, is that these problems occurred 30, 40, 50 years after the childhood abuse. It's like the brain gets tuned in the wrong way. The whole endocrine system and the whole stress response system gets tuned in the wrong way. So I use that exact same study in 219 of my patients. I report the first 175 in the book, and I'm writing up the whole study now for our plastic surgery journal. And these were patients that I studied only post-operatively, because I wanted to, first of all, I wanted honest answers. I wouldn't give this patient as an intake form to someone waiting to see me about plastic surgery. Second, I wanted to be able to put the answers in context. I wanted to know, what was this person like? How much pain medication did he or she take? How much of a drain on the office resources were they? Did they call all the time? Did they keep their appointments? Were they happy afterwards? How demanding were they? And I also inventoried all their health problems. And we found that the prevalence of childhood abuse and neglect was, in my reconstructive patients who came in for skin cancers, was 70%, which is not that different from the Kaiser number. But in patients who'd had multiple cosmetic surgeries, it was over 90%. And there are 5 areas in which my patients were much higher than the Kaiser Permanente. Emotional abuse was 50% in my patients, where it was about 11% in the Kaiser patients. Emotional neglect was 2.5 times as high. Drug abuse, alcoholism in the family, mental illness in the family, and physical neglect. So in those 5 areas, my patient's data was statistically significantly higher than it is in the
In terms of adverse childhood events
right.
that they had,
Interestingly,
yeah,
I'm
it
sorry.
correlated with the people that you had seen who had bad experiences.
All across the board, the most, 80% of my patients had at least one answer, but the patients who'd had the most surgery and the most problems um, uh, in terms of self-worth had the most childhood abuse and neglect. And in my patients, the number of positive answers also corresponded with adult health. So when I gave this the first time, my colleagues said, well, doesn't that mean we can use the adverse childhood events study as a screen for plastic surgery? And I said, no. And the reason is because people are resilient. And that's what I was able to uncover with this, because I discovered that as I tested more and more patients, I couldn't predict someone's ACE score, even though
Fascinating.
I
Yeah.
knew them very well. I'd seen them go through surgery and complications. The patients who were the most wonderful, most grateful, most successful, pleasant people everybody in the office loved would have a score of 8 on the ACE study. And I'd say to them the next time I saw them, so how come you aren't a homeless person?
Yeah.
How come you're so successful? And they all said a variation of this. I had a grandmother. I had a coach. I had a teacher. I had a minister, someone outside the destructive family core that believed in them and that gave them a sense of self-worth. So that's the last chapter of my book, is really about resilience as I define it, not as a mental health professional, but that's what makes the ACE study so interesting. And if you look at the statistics, resilience acted like an antidote to childhood trauma. So patients who were resilient, who had a good sense of self-worth and optimism and a life philosophy, these were people, even with a high ACE score, they were more likely to be happy after surgery, and they were healthier, fewer health problems.
Yeah.
Very
Yeah, that's fascinating to hear. And of course, I've interviewed a lot of people about trauma, and some of them have been saying everybody, nobody gets through this life without trauma. That everybody's had some trauma, and yet not everybody develops all of these terrible uh, sequelae in their life,
right.
later on. And so there is this resilience that you're talking about, and
And not,
even
oh, go ahead, excuse me.
I was just going to say, even veterans returning from the war who were exposed to horrible events, very traumatizing things, and some get PTSD and others don't.
Right.
And so this is, a very current and lively field of interest right now.
That has been studied, and the people, so the likelihood of getting PTSD doesn't depend on how severe the battle trauma was, the war exposure. It depends on your personality before you went into battle.
Mhm.
So um, I've lost my train of thought, but finish what you were saying.
It happens to me all the time. I wanted to ask, since you're the only plastic surgeon I've ever spoken with, about liposuction. Now, I've got more belly fat than I want, and supposedly it's very unhealthy to carry that in that part of my body. But I have the impression that maybe if you get liposuction to suck out the fat, that maybe it just comes back, or would it change the longevity prognosis?
I think those are they're almost two separate questions. If
Okay.
you suck out the fat cells, the um, the obesity doesn't recur, or the excess fat doesn't recur in that area because there's no fat cells to take up the fat. But it also depends on where the fat is located. Core fat in the center of the abdomen, people with the barrel abdomens and the large waists and smaller hips and bellies. Those are the ones with intra-abdominal fat, and that's the most dangerous kind. That's the one that's associated with inflammation and a lot of kinds of adult illnesses, including cancers. So that's the one where they call it metabolic syndrome, where you have you're a big central sort of core of fat. That's different. So if people are overweight and they have that kind of fat, that's not a liposuction issue. That's a change your diet issue and get rid of insulin spikes, lower carbohydrates, protein, good carbohydrates, fruits and vegetables, and very little sugars and starches. That's what makes that difference, and that's the health connection. So liposuction is good for, it's most ideal for people who are a good weight, who have problem areas, a little in the belly or a little in the hips or something that they can't get rid of, where it's a contouring problem. It's not as good, in my opinion, for people who are massively overweight or who have a generalized obesity. But that's not my area, and I'm sure there are surgeons who operate on those patients as well.
Yeah. Yeah, it brings to mind that when I go to my skin doctor, actually dermatology thing, they've got various products that they're sort of promoting. And one is called CoolSculpting, which I guess they freeze they kind of freeze areas of the fatty areas in segments. And supposedly the fat or some of that material just gets excreted from the body later. Do you have any thoughts about that? I'm not considering it.
I'm the wrong one to ask. I think I haven't done it. I don't own machines. Whenever I look at results any surgeon presents, I always say to myself, would I be proud if that were my patient? And I'd say, to me, the results are subtle. They're not invisible, but they're subtle. And the surgeons say the patients are happy. And it's a simple procedure. So, aren't we all looking for the simple thing, the lunchtime facelift and the quick way of getting rid of fat? And all these things, there are a lot of kinds of plastic surgery that have sex appeal like that because they're nice and simple and quick, and they are supposed to produce wonderful, long-lasting results. But it's like someone, maybe I'm cynical, it's like a gynecologist promising you a 3-month pregnancy because you're in a hurry. It's just not possible. You want to change nature, nature has its own timetable, and you have to change. In plastic surgery, you have to change certain anatomical structures. So I think you probably can get small changes, and apparently patient satisfaction is high, but it's not my area.
Okay. Do you have any advice, as we kind of wind things down here, do you have any advice for listeners or viewers out there who might be considering plastic surgery?
I think it's most important to know yourself. The axiom in plastic surgery has always been that the motivation has to be internal, not external. I had a mother come in with her son. He's 40 years old. She's mid-60s, and she says, we don't want a bump on our nose. Now, there's a boundary issue there. So that's an extreme example of external motivation. The mother is having the surgery, and I see patients who still remember how their parents pressured them into surgery as teenagers, and they still hate them for it. So I think the motivation has to be internal, but I think as much as possible, people need to understand whether they are being driven by a sense of defectiveness or a simple dislike of an anatomy that's not the way they would like, because that really separates the problem patients from the ones who are going to be happy with surgery. You can't get self-worth from plastic surgery. You have to get it elsewhere. And it's only when people come out of those addictions, whether it's to plastic surgery or alcohol or drugs or anything, and recapture their sense of self, that you see their faces change. You mentioned the face of trauma. If you want to look at page 221 and page 222 in that book, you'll see what I was talking about. Because you see pictures on patients on 221 who were relational patients that were happy after their surgery. And then you turn the page and you look at patients on the other page who were motivated by different things and had different feelings about themselves. And the eyes look totally different.
Okay, folks, you will have to buy this book in order to have the experience of looking at page 221 and 222. And I just looked and I could see the difference. It puts me in mind, though, that often I see plastic surgery ads in the newspaper before and after, and often it's not that dramatic. I'm kind of, you know, uh, do other people report this as well?
Uh, Presumably the surgeon thinks they're going to be selling points. I always, it's the, what I said before, I always look and say, if that were my patient, would I be proud? And I guess the answer is not always, but there's a lot of self-promotion going on in plastic surgery. I think patients have to be discriminating.
Uh-huh. That's a good wrap up right there, I think. So, Dr. Mark Constantian, I really want to thank you for being my guest today on Shrink Wrap Radio.
It's a pleasure. Thank you for inviting me.